Thank you, everyone. Welcome to today's Live from Cleveland Clinic broadcast. We've got over 1,100 healthcare providers registered for today's event from across the globe, representing 90 countries. We have special thanks to our industry sponsors for their generous commitment to this program. We truly couldn't do this without them. So we'd like to thank Cook Medical, Janssen Biotech, Medtronic, and Olympus Corporation of the Americas. Our faculty includes our director, Michelle Kim. I'm Shirley Paskey, a staff gastroenterologist here at Cleveland Clinic, as is Lindsay Russell. We also have one of our oncology dietitians, Amanda Bodie, Dr. Kunza Syed as one of the staff faculty here as well on the nutrition support group, as well as our nutrition fellows, Jessica Socio and Mark Zamanek. We'll start with Dr. Lindsay Russell presenting the latest on nutrition assessment.
Thank you so much. I'm just going to share my screen here. I think you guys can see that. So welcome, everyone. This is very exciting. I'm going to start off with talking about just some updates in the nutrition assessment and kind of go over some tools that we have and that we can use in clinical practice to accurately assess our patients. These are my disclosures. These are my objectives for today. So really applying malnutrition diagnostic assessment tools for clinical practice, delineate different modalities for assessing body composition, and then looking at functional testing for muscle integrity, and also looking at a little bit of metabolic assessments as well. So these are kind of the diagnostic tools that I'll be going through today. So why should we care about this? Well, we're all very passionate about malnutrition and treating it as such. We do know that mortality and morbidity are increased in patients defined with malnutrition. And the role of us healthcare professionals are really vital in recognizing patients at risk and treating it accordingly. And I also want to highlight that people are quite unique based on disease pathology and also leading to this concept of precision medicine and using tools that we have to cater our assessment and treatment strategies for the patients itself. And I really love this image highlighting that these are two patients with very similar BMIs, but you can see on imaging that they have very various body compositions. So you can see different in the colors there, subcutaneous fat, visceral adipose tissue, muscle, and intermuscular adipose. So kind of that integrity of the muscle, or the quality of the muscle, if you will. So patients can be very unique, and it's our jobs to kind of apply that to our assessment of the patient. So moving on, some screening and diagnostic tools. There are very many validated out there, but due to time today, I'm going to highlight one, and that is the Global Leadership Initiative on Malnutrition, or the GLIM criteria. And this is the reference there for further assessment in these guidelines. But really the outline of this is patients need to be screened and validated. Those at risk for malnutrition have to have a diagnostic assessment. The unique thing about GLIM, it looks at both phenotypic, which is the weight loss, low body index, or reduce or low muscle mass, and then look at the etiology leading to malnutrition, which I'll touch on the next slide. And then also looking at, do they meet the criteria for malnutrition, and then determine the severity and the grading of it. So briefly, they look at the etiologies I want to talk about is this malnutrition related to chronic disease? So as a gastroenterologist, this might be inflammatory bowel disease or chronic kidney or liver disease. Is there active inflammation in that setting that might lead to malnutrition? For acute disease, this is mainly for acute illness, for post-trauma or burns, for example. So that has a lot of inflammation, kind of cytokine storm that can lead to malnutrition. And then also the third kind of category would be starvation or socioeconomic. So that would be kind of limited oral intake leading to malnutrition. Very briefly at the bottom, I looked at the different stages here. So you can see stage 1 is moderate malnutrition or severe malnutrition. And a lot of the guidelines for diagnosing malnutrition looks at, is there a degree of weight loss, look at the low body mass index, and then the reduced muscle mass, both on validated assessments and cutoffs for patients based on age, which you can see here. So GLIM is one of the common diagnostic criteria for malnutrition. And I like this one because it kind of highlights the etiology and the phenotypic for our patients. Moving on to screening tools and diagnostic tools for body composition. I'm going to go through different modalities just to get a little taste, and then some references for you all to look at it for more reading. So body composition for CT. So the pros for this is high resolution to look at the different tissues as I highlight in this image repeated here. You can look at muscle quality, and by means of that is muscle size and also that adipose tissue within the muscles. So we know patients with higher fat deposition in the muscle, then it might not be as high quality as not. You can separate subcutaneous and visceral fats, so that's helpful. And then the pros in some patients like cancer or IBD, they get serial CT scans. So you have access to that for different programming to assess their body composition. Some cons for CT scan is radiation exposure, some costs, and then there's ongoing studies now to look at specific cutoffs and what's normal and what's not. Next is DEXA scans. So this is used for also bone density as well. So the pros for this is it's fast and non-invasive. You have direct quantification and proportion of body compositions, and you can really look at both regional and whole body measurements. There's some that looking at limb to height length and things like that. And then cons for this could be access, cannot determine muscle quality per se. There is some height and weight restrictions for DEXA machines. And again, there's some differences in specific cutoffs, specifically with sex and different ethnicity groups as well. Body composition for BIA. So this is assessing conduction through different tissues. So you can see in the image there in the bottom right, there's two electrodes that are attached, and then they send the electrodes through, and then depending on the density of the material, then that could affect the inflection of the electrodes. So fat-free mass, you can look at visceral protein, intracellular water, extracellular water, and bone mineral would be in that kind of grouping. There's total body water, which has both intracellular water and extracellular water, and then there's different density in fat mass with the conduction to go through. This is, you can see on the right top photo that it's quite easy and portable to obtain in clinic. You just attach the electrodes and take your measurements on your machine. The cons is that it's not very validated in ages of over 80, and it really relies on consistent body shape. So, and it's also very sensitive to recent water ingestion or activity, and it can overestimate total volume of water. So there are specific cut points for specific populations, but this is a tool that could be used to determine body composition. I also want to touch on MRI machines. So this is an example here of in the lower extremities, looking at two different patients to see for body composition there. And you can see in patient A compared to patient B, there's a different composition, even though they have the same circumference of their calf, that there's more musculature versus subcutaneous fat in these two patients. The pros are it's limited in radiation, and it can really clarify soft tissue as very well. The cons is the cost of it, and there is some limitations in patients with hardware due to artifacts. Lastly, at Cleveland Clinic, this is a slide that we have been implemented in some of our research protocols as well, and looking at ultrasound to assess for muscle integrity and also muscle thickness. The pros of this is portable, no radiation, and can be used over time for muscle changes, and you can clarify soft tissues as well. The cons is the trained personnel, limited quality of the exam. It really depends on the tissue composition and presence of edema. So moving on briefly for functional status, a lot of this is not only how much muscle you have, but the function of the muscle. So there's two big tests that we do is the skeletal muscle strength, which is the hand grip strength that you could do on both your dominant or non-dominant hand, and then also your chair stand test. So there's different cutoffs. So there's either the time that it takes to sit up and down 5 times, or how many times you can do that in 30 seconds. And you can see the demonstration there in that photo. So this is things that you can apply in your clinics to assess functional status for patients. I also want to look at and provide you with the SARC-F screening score for sarcopenia, and this looks at strength, assistant in walking, rise from chair, climb stairs, and falls. So it's a little bit of a whirlwind, but it's a short time today. The last thing I want to leave you with is metabolic rate. So what I'm looking at is energy expenditures for people. So total energy expenditure is resting and also activity related. There's the thermal effect of feeding as well as the basal metabolic rate. So why do we care about this? Well, when we want to feed someone and treat their malnutrition, we want to prevent underfeeding, especially in the hospital setting, and also prevent overfeeding for these complications outlined here. In the past, we did direct calorimetry to measure heat and as well as gas exchange. That can be very difficult to do. This is where indirect calorimetry can come in. So this determines energy expenditure from oxygen consumption and CO2 production based on the Weir equation here. Indirect calorimetry can be measured in mechanically ventilated patients in a closed circuit or with a canopy on spontaneously breathing patients. This is a really nice review article in the Clinical Nutrition of ESPN, so I encourage you to read this. But a lot of the indications for indirect calorimetry is patients who have that inflammatory bowel disease, anorexia, and a lot of these chronic conditions where our predictive equations aren't as accurate. I want to highlight here that in acute critical illness, there's many aspects that can affect the resting energy expenditures as measured by the machine, and that includes minute ventilation, heart rate, percent burns, as also hypothermia and neuromuscular blockade. What I mean by that, we also measure the respiratory quotient, which is the ratio of the CO2 produced and oxygen consumed. And you can see by this graph here, depending on where that ratio respiratory quotient is, you can get a sense of if the patient's being overfed or have an increased carb intake, or on the other side of it of underfeeding or a high-fat ketogenic type diet. And we want to aim for that optimal range of 0.8 to 0.9. Here is a brief overview of some things that can increase and affect the ventilated oxygen and ventilated CO2. So I'll leave that there for you guys to read. But basically, in some settings like overfeeding or obesity, then you have different ventilation schemes. And I want to leave you with this. Indirect calorimetry is very a useful tool, especially in critical illness, to really gauge where patients' metabolic needs are. And it's also been expanded to the outpatients as well, which has been shown to be superior to predictive equations. So with all that, I think I made it on time, but the take-home points is malnutrition is common. So please screen all your patients, and those who are screened positive, continue with a diagnostic score to both diagnose malnutrition and stage the malnutrition. And then body composition is really essential and more accurate than physical examination, and really can help get a better picture of patients' nutritional status. Different modalities that I touched on can be used. Remember to add in functional status and with the composition, which is key, and then also look at metabolic rates to cater nutritional needs. And with that, I would like to hand it off to my colleague, Dr. Paskey, for the next section.
Thank you. Okay, so I'll be talking about intestinal insufficiency to intestinal failure, and the objectives for this are to describe some of the causes, recognize signs and symptoms of intestinal malabsorption, diagnose and correct nutritional deficits that result from intestinal malabsorption, and also identify patients with malabsorption in need of advanced therapies. So there's a spectrum from intestinal insufficiency to intestinal failure. And I like to describe it as intestinal insufficiency starting out with somebody who may have had a limited surgery or limited dysmotility, and where they may have to take some additional oral supplements. This can progress to more of a moderate intestinal failure that could require enteral support, or even severe intestinal failure, which requires parenteral support. And in our objectives in treating this condition, we want to have somebody that goes from an intestinal failure and to downgrade them to sort of moderate or intestinal insufficiency between the combination of dietary, pharmacological, surgical interventions. So the approach to this would be to start with identifying the etiology for intestinal failure, and then move on to disease-directed therapy at the baseline, symptom management, short-term and long-term nutrition goals. Intestinal failure may occur due to one or multiple etiologies. I like to classify things broadly as being surgical or structural conditions, and this includes short bowel syndrome, malabsorption, bariatric procedures, surgical bypass or fistulas, and then primary mucosal disease, which may be from congenital, immune-mediated, medication-mediated, other infectious, or even severe malnutrition on its own. Dysmotility etiologies, which again can be congenital, neuropathic, myopathic, or medication-related. And then finally, obstructive etiologies due to adhesive disease, strictures, radiation, or sclerosing peritonitis. We often will see a combination of all of these things in different severities, which is why we need to take a broad approach to treatment. We'll be focusing on the surgical and short bowel syndromes for the remainder of today's presentation. So when it comes to the approach to short bowel syndrome, the most important thing is to start with getting an idea of the patient's anatomy. And that's going to involve looking at your operative reports, or maybe even doing some additional studies to get an idea of how much bowel is in continuity. And based on the type of short bowel syndrome, which can be classified as type 1, which is with a stoma or colon out of continuity, versus type 2, which involves a jejunal colic anastomosis, but loss of the IC valve, or type 3, with a jejunal-ileocolic anastomosis, with preservation of the IC valve and colon in continuity. The fluid needs are going to be different based on the amount of remnant bowel. Individuals with type 1 and a jejunostomy will have a high amount of fluid losses and problems with rapid transit and hypersecretion. Patients with type 3 on the opposite spectrum tend to have less issues with fluid losses and also some potential for ileal adaptation, but run into significant problems with fat malabsorption, nutrient malabsorption, and calcium oxalate stones. And then the patients with type 2 are somewhere in the middle, depending on how much small bowel and colon they have remaining. Getting an idea of where you've got site-specific nutrient absorption in normal bowel will help you predict what the needs are going to be for your patients with short bowel syndrome and post-surgical anatomy. What you can see here is that the duodenum and the jejunum are really responsible for absorbing the majority of your macronutrients, carbohydrates, proteins, and fats. And then unique to the ileum, we've got the reabsorption of bile salts, magnesium, and then vitamin B12. And then the colon helps with short-chain fatty acid absorption. And this can be really critical for calorie recircling with the production of short-chain fatty acids. And you can get up to 20% calorie recovery from that with carbohydrates. So next step, when you have an idea of what the anatomy is and where you're going to have deficiencies, is to evaluate for electrolyte and nutrition deficiencies. There's a basic set of labs that I include in most patients here for your slide deck. And then based on the anatomy and any symptoms or high-risk profile, I'll order some extended nutrition labs too that include particularly things like fat-soluble vitamins, some of the B vitamins that would be lost with high output, vitamin C, some of the other trace minerals, chromium and manganese, particularly if they're on TPN, or essential fatty acid profile, tetrene triene ratio for those with very short amounts of small bowel at risk for essential fatty acid deficiency. We couldn't do a composite evaluation without a physical exam. And so this will involve the measures that Dr. Russell just finished talking about, and this is included on every patient. To get a better idea of how the small bowel and the colon are structured and function, imaging, motility, and stool studies can really help as a guide to therapy. For finding an idea of the structure and how much bowel is in continuity, if the operative report doesn't give an idea, we can do various imaging studies. It'll also identify the presence of dilated bowel, the presence of a partial bowel obstruction, and give you a rough idea of the remaining amount of bowel available. And this can be done fairly easily with any cross-sectional imaging study or a small bowel series. For motility evaluation, we've got the usual tests with gastric emptying time, small bowel transit time, colonic transit studies, and knowing where things are at as far as the motility can help for identifying which patients are going to be benefiting from either pro-motility in some cases or optimization of antidiarrheals. And then mucosal evaluation can be done in a variety of ways with endoscopy, enteroscopy, capsule, as well as colonoscopy. But correcting any areas where there's an opportunity to heal the mucosa will ultimately help with absorption and fluid balance as well. And this underscores the importance of evaluating the primary GI disease. And then finally, I always say, don't forget about the stool studies. If you're going to collect stool studies, make sure you get them for everything, but the fecal fat, fecal elastase, and electrolytes, any inflammatory markers and infectious pathogens can also help direct therapy. So the basic principles we'll move on as far as just management are to separate fluids from solids, to eat at regular intervals because the bowel can only absorb so much at one time. So you're really taking advantage of just feeding it in an amount that it can take in at any given time. Avoiding concentrated sweets and limiting sugars to 10 grams per serving and focusing more on a single starch. I always say digestion starts in the mouth, so chew the food well. And you want to be sipping the fluids between meals, ideally isotonic fluids and oral rehydration solutions. And it really, the case in point is to keep in mind that oral and enteral nutrition requirements are higher when someone has malabsorption. So those estimated nutrient needs that you get from the indirect calorimetry or equations on how much nutrition someone needs may be completely different for somebody that's depending on absorption of the nutrients from a defunct gut and intestinal failure. So a reminder of oral rehydration solutions. If you remember your World Health Organization specific ratios of sodium and glucose to help turn on sodium glucose co-transport to absorb fluids in the small intestine. There are many commercial and homemade absorptions available. And the great thing about these is you get the enhanced absorption of both fluids and electrolytes to replace what's being lost in the GI tract. The key is to really sip these, not gulp them. There's nothing that can overcome a gallon of fluids in a short period of time that's going to go straight through. But sipped over the day, these are much better tolerated. Now, this is a slide that you can do a screenshot of for just some of the guidance for electrolyte replacements and some of the replacements that we use in our patients with short bowel syndrome. Potassium, magnesium, phosphorus, and bicarbonate are the ones that we end up replacing the most, and using the oral rehydration solution predominantly for the sodium increased requirement. And so just one note here for magnesium, it's universally cathartic, but from best to worst, I'd just like to highlight we've got a few supplements that are a little bit better tolerated from a GI perspective. The MG Plus protein, which is trademarked, and we also, for patients that really have a difficult time, there's also Epsom salt baths for some transdermal absorption. For phosphorus, some of the problems that we can overcome are focusing on foods rich in phosphorus prior to the supplements, which are universally cathartic as well. So for oral nutritional supplements, so these are the things like, that you can get over the counter or by prescription. We prefer the ones that are actually lower in sugar, higher in protein. And these can be great for patients to have as an easy snack or beverage, going for less than 10 grams of sugar per serving. And again, gradually sipped over the day in between meals. For fat malabsorption, this can be a big problem for our patients. We will use MCT oil, which doesn't require intact biliary function to absorb, and just drizzle it on food for some extra calories, and consistently over the day, it all adds up. You can also get some topical absorption for those with essential fatty acid deficiency. Apply to skin after bathing or before bedtime. I've given some examples of basically edible oils that can help for these patients, particularly your type 3 short bowel syndrome patients. When it comes to diarrhea, antidiarrheals are really the mainstay of symptom management, and you can really help out your patients by, telling them how to take them. Loperamide is the preferred antidiarrheal, and dosing is up to 8 per day. Diphenoxylate atropine can sometimes be added on, 2 tablets up to 8 per day as well. And the timing of these in the administration can be really critical. So you want to time them ahead of the main meals and also before bedtime. So to help people retain their meals a little bit longer and allow for a little bit longer for absorption, and then to avoid or lessen the amount of nocturnal bowel movements. These tablets can be crushed to improve absorption as well. Soluble fiber can be very helpful for those who have colon incontinuity, again, for making those short-chain fatty acids with fermentation and some calorie recovery. Psyllium husk or Metamucil has very good evidence for, and also Citracel and Benefiber tend to be well tolerated. It's best taken, as a slurry. So as opposed to the labeled use for constipation, which is in a large glass of fluids where you're trying to deliver more fluid to the colon, you want to do the opposite. So you want a small amount of fluid and a larger amount, relatively speaking, of the fiber to help to bind the extra water and help to make the bowels a little bit more manageable. For those with an ostomy, the benefit is a little bit more limited, but in some can just help a little bit with thickening the ostomy output and make it a bit more manageable. Don't forget about reducing gastric hypersecretion, particularly early phase of surgical resection with proton pump inhibitors, and then also famotidine. The nice thing about famotidine is it can be added to the TPN, and PPIs are not compatible with TPN. There are other anti-secretagogues available, including somatostatin analogs, octreotide, somatostatin, that helps to slow intestinal motility and reduce secretions, but it does require monitoring, and you have to keep in mind the side effects with biliary side effects, hypoglycemia, and worsening fat malabsorption. For those who have issues with hypertension, clonidine can sometimes be helpful too, and you can get a little bit of a dual benefit with the patch. I make mention of cholestyramine in the sense that it actually has very limited role in short bowel syndrome. We see it used often in patients, but really it just helps to reduce a little bit of the bile salt irritation and diarrhea. But most patients with short bowel syndrome, they're almost universally bile salt deficient. And so cholestyramine actually worsens their symptoms of diarrhea and worsens their fat malabsorption. And so I cut out cholestyramine in more patients than I prescribe it to. The role of pancreatic enzyme replacement therapy is a bit of a diagnostic challenge. Because you've got patients who have, altered anatomy, for example, with a Roux-en-Y or a biliopancreatic diversion, or you have people with, a high output ostomy. And so interpretation of the stool pancreatic elastase can be a little bit difficult because you've got mismatched timing between the pancreobiliary secretions in the food in the case of altered anatomy, and then diluted pancreatic elastase in the high output ostomy. But nevertheless, it can be helpful, and it has been shown to be helpful in some patients. So it's something to keep in mind for those who have malabsorption. It's just adding to the pill burden. Small intestinal bacterial overgrowth occurs particularly in patients with type 2 short bowel syndrome, where they've lost the ileocecal valve, and you can get more reflux between the small bowel and the colon, and also in those who have dilated areas of small bowel due to strictures or the natural adaptation process. Breath tests are difficult to interpret because of the shortened transit time when you've got short gut. And small bowel aspirates are difficult to collect. So in many cases, we end up doing an empiric trial of antibiotics for those with symptoms. Also keep in mind with antibiotics, some can also develop fungal overgrowth, and that this would be treated with an antifungal agent. So nutrition support is indicated when the nutrition needs cannot be met orally, and you've sort of gone through all the diet, lifestyle, basic pharmacologic management. For enteral support, you've got your gastric, post-pyloric feeding or jejunal feeding. I would say for short bowel syndrome, you actually really want to try to feed the stomach because they've got less small intestine. So you want to get as much food into the small intestine as possible, including the duodenum. And then we reserve parenteral support for either IV hydration or full parenteral nutrition in those who cannot meet their fluid needs or nutrition needs with a combination of oral and enteral. I want to make one note of trophic factors to facilitate parenteral support weaning. And so if you've got somebody who's doing all the things, but they do require PN, there are now GI-specific growth factors in the form of GLP-2 agonists. GLP-2 is a hormone that's secreted from the L cells in the ileum and the proximal colon, and serve as sort of an ileal brake and also stimulating the growth of the small and large intestinal mucosa. And so these drugs are highly effective in helping patients to wean the amount of parenteral support they require and sometimes simplify the medication requirements that they have. A few medications that I'll just make mention of for practical purposes off-label. If you've got a patient who also has IBS, diarrhea predominant, they may benefit from alexadoline if they've still got their gallbladder. They've also got your GLP-1s, which are getting increasing use, especially for people with fast motility that you want to take advantage of their gut slowing effects on, and hormonal effects as well. The ones that have been formally trialed in short gut include Byetta, Bydureon, and liraglutide. But we have others that are on the market now as well if your patient has a requirement for those. And there are also some case studies for crofelemer being effective as well that blocks chloride secretion by a CFTR. One mention of surgical management for short bowel syndrome. These are done in specialized centers. If you have a patient with colon out of continuity, don't forget about it and see if you can get the colon put back into continuity to help reduce their need for PN particularly, and improve their quality of life. There are multiple procedures available. And then intestinal transplant remains for those who have really failed everything that I've mentioned up to this point and have developed complications related to PN or a very high risk for developing complications. So in summary, when it comes to positioning therapies, the core is really diet and lifestyle. In somebody with, an early resection, starting a PPI is important, and then optimize the antidiarrheals, and then other anti-secretagogues, and consider hormonal therapy for those on parenteral support. Also treat the underlying disease and address associated complications, and don't forget about referral to an intestinal rehabilitation center at least once for those really complex patients that are dependent on parenteral support. So hopefully you've appreciated the intestinal malabsorption syndromes, the importance of treating it, and when to start nutrition support, and the use of specialized centers when available. And now I'll hand it over to Amanda Bodhi, who will discuss the ins and outs of refeeding syndrome.
All right. Well, thank you so much. It's a pleasure to be here today to be speaking with our physician nutrition experts at Cleveland Clinic. As mentioned before, I'm a registered dietitian and I'm a board certified specialist in oncology nutrition. My focus in the outpatient setting is managing refeeding syndrome in enteral nutrition, and I'm really pleased to be speaking with you today about the modern approaches to nutrition therapy. Next slide. Today, we are going to explore a very important nutrition and medical topic called refeeding syndrome, which is a complication of nutrition therapy that can be fatal if missed. It develops when a patient is in a starved or catabolic state and is suddenly refed. So think of a patient with esophageal cancer and an obstructing mass who is unable to eat for weeks and already profoundly depleted of essential micronutrients. If that patient is given enteral access and then rapidly refed, next, without preventative strategies, the abrupt shift back to an anabolic state can trigger refeeding syndrome, next, which is a cascade that includes electrolyte shifts, fluid overload, thiamine depletion, and ultimately multi-organ dysfunction. And what is striking is that despite decades of research and even descriptions going back to antiquity, patients are still discharged every day without proper safeguards in place. Next. Refeeding syndrome is not a rare complication. It's actually common, predictable, and preventable, yet it remains under-recognized across many care settings. When it occurs, the consequences are serious, and physicians are responsible for anticipating risk and prescribing nutrition safely. Unfortunately, multiple surveys show that this syndrome is poorly understood in the medical community and is often not taught in medical school. So in this session, I will kind of quickly, in a short amount of time, try to review how the starved state, micronutrient deficiencies, and rapid refeeding converge to cause what we call refeeding syndrome, and what strategies we can use to prevent it. Next. So in starvation, blood glucose falls and micronutrient intake is negligible. Insulin drops and glucagon rises. Glycogen stores run out within 24 to 48 hours. And within this starved state, by day 2, fat breakdown and ketone bodies become the primary fuel source. By day 3, the amino acids are being used for gluconeogenesis, and importantly, those intracellular electrolytes, potassium phosphate and magnesium, are depleted, as well as thiamine stores as well. But serum levels may still appear deceptively normal because of homeostasis. So the body is adapting to survive at this low energy cost, but this fragile balance really collapses when feeding resumes. Next. So during refeeding, glucose re-enters metabolism and insulin secretion surges. This really drives those electrolytes that we thought were really stable in the starved state back into the cells to be utilized. And this is where it becomes dangerous. It causes these dangerous drops in potassium, magnesium, and phosphate. And at this time, thiamine is also really rapidly consumed, which is where we risk Wernicke's encephalopathy. So sodium and water retention can occur, leading to edema, pulmonary congestion, and heart failure. Meanwhile, phosphate depletion impairs ATP synthesis, red blood cell function, and muscle strength. And the result is really a systemic metabolic crisis. Next slide. So as we look at what the clinical picture looks like in refeeding syndrome, it's important to recognize it's not just one organ or one type of symptom. It can look like a lot of things simultaneously. And so starting with the heart, patients may develop dangerous arrhythmias, worsening heart failure, or sometimes they, in very severe cases, can have sudden cardiac arrest. With the respiratory system, we may see the diaphragm weakening or other muscles weaken, which could progress to respiratory failure, as well as shortness of breath being caused by edema being pushed into the lungs. With the neurological changes, they can be very subtle at first, and they can look just like confusion or delirium, but it can really escalate to seizures or Wernicke's encephalopathy if the thiamine deficiency is not corrected. And then finally, with digestive systems, patients often report nausea, vomiting, or constipation, which might be mistaken to either their underlying illness or, and a lot of times, enteral nutrition. We have some of these intolerance issues as well. So we have to be really careful that we're not misdiagnosing the digestive issues from refeeding system as an intolerance to tube feeding. And what makes refeeding syndrome particularly dangerous is that these cascade of symptoms can appear really suddenly, and they can appear within any phase of the feeding process. So that can be within the first couple days up to a few weeks if it really is difficult to get that person fed to goal. And so if we as clinicians are not anticipating them, these signs and symptoms can be easily missed or mistaken for something else. Next slide. When refeeding syndrome develops, it's not just an electrolyte issue, it translates really into worse patient outcomes. Studies show that patients with refeeding syndrome are 2.7 times more likely to require transfer to the ICU when they're already in the hospital. Their hospitals on average are 1.5 times longer, and they experience higher 60-day mortality. They're also significantly more prone to developing a secondary infection. And then importantly, this is not a rare problem. This is not a problem limited to just a narrow patient population. Those at risk span a really wide variety of conditions. Patients who are undergoing bariatric surgery during the fasting time before surgery or post-surgery, or even years after surgery because of thiamine uptake, may develop refeeding syndrome or Wernicke's encephalopathy. In my practice, I see many patients with cancer undergoing refeeding syndrome, which we have to do a lot of work to prevent. And then you may also see this in other cases like alcohol or substance abuse, critically ill, patients who have food insecurity, and really anybody who has a prolonged NPO status. So this is really a syndrome that cuts across specialties: surgery, oncology, medicine, intensive care, meaning every physician watching today will encounter patients at risk for this. Next slide. So let's walk through a structured approach to identify patients at risk. And first, what I would suggest and what the consensus guidelines suggest to do is perform a nutrition risk screening and check baseline electrolytes and fluid status. Next. And in my practice, I typically order a CMP or pen that order to a physician a CMP along with a magnesium or phosphorus, though some clinicians prefer a renal panel. And then the next thing is to determine the refeeding syndrome risk. So on the right, I've included the Aspen consensus guidelines. Remember, it really only takes one or two of these criteria to flag a patient at risk. And these categories include low BMI, weight loss, poor or minimal intake, abnormal baseline electrolytes, evidence of muscle or fat loss, which Dr. Russell spoke about earlier, or the presence of a significant disease. Now, once you have identified the risk, proactively supplement patients with magnesium, phosphorus, and potassium once you see those baseline labs. So next. So supplement those electrolytes. Make sure you're giving thiamine up front. For these patients at risk, everybody should really be on 200, 300 milligrams of thiamine for at least the first week or so. And then you would also initiate calories very slowly. You go, depending on, and we have a case study later, you'll really talk about the rate of calories depending on that risk, but start low and go slow is the primary principle. And then finally, continue to monitor labs and clinical signs closely. This vigilance is really needed to extend beyond the hospitalization, especially with those patients that we discharge very closely, or provide enteral or parenteral access in the outpatient setting. We need to make sure that we're checking not only during the hospitalization, but later than that as well. Next slide. So I'd like to highlight the proposed refeeding protocol developed by Krukite and colleagues at the University of Bern in Switzerland. There are a few key features of this protocol that I think particularly valuable. First, it differentiates the nutrition advancement based on risk level. A low risk patient in yellow there doesn't necessarily need to start as cautiously as a high risk patient. And this framework allows for clinical judgment rather than a one size fits all approach. Secondly, I want to emphasize the importance of fluid management. In high risk refeeding, the protocol uses an early fluid restriction, which can be critical in preventing overload, heart failure, pulmonary edema. And here's an important clinical pearl: use caution when treating dehydration. The use of normal saline alone may worsen refeeding syndrome. So some experts suggest that if you are treating dehydration, you use a mixture of half normal saline with dextrose within it. But it's really critical that this approach is used only when you have a really good understanding of the metabolic processes here, have tight glucose control and monitoring in place, and you are providing thiamine supplementation with IV fluids. So the overall message here is that risk stratification should drive nutrition support, including calorie initiation, fluid management, and sodium restriction as needed to control the edema, and then tailoring therapy to the risk so that we can support nutrition, getting that patient to goal as soon as possible while minimizing those complications. Next slide. And as I said before, prevention really doesn't stop after day one. Patients at risk for refeeding syndrome often require daily labs or sometimes every 12-hour labs for electrolyte and glucose during those first 3 days, especially. Along with frequent clinical monitoring for fluid balance, neurological changes, and muscle weakness. It's important to know that ECG monitoring should be considered to detect cardiac arrhythmias early. And if you're in the outpatient setting starting this, you need to make sure that you have access to that. Clinically, we need to be weighing our patients daily in the hospital and at home or in the outpatient setting to assess for edema. We need to be watching for respiratory distress and watching for GI intolerance. And those, like I said before, those first 3 days are really the most critical, but we have to be monitoring beyond that. And the challenge here is that with today's emphasis on early discharge, many patients are sent home before they are metabolically stable. They might be medically stable, but they may not yet be metabolically stable. And so typically monitoring and nutrition advancement need to continue for up to 14 days and sometimes even longer with patients that have intestinal abnormalities or different surgical procedures to their GI tract. So depending on how well a patient absorbs and tolerates feeds, it raises the question, who is responsible for adjusting nutrition and monitoring for signs of refeeding after discharge? So unfortunately, many patients leave the hospital without a clear contact for tube feeding management. So we really just want to make sure that we are supporting our patients and communicating well between physicians and providers so that there is good, clear discharge and nutrition follow-up so that we can advocate for better outpatient nutrition coverage and make sure that these patients are safe. Next slide. So the bottom line is refeeding syndrome is common, predictable, and preventable. Every one of us will encounter patients at risk, whether in oncology, surgery, ICU, or primary care. The responsibility lies with us as medical professionals and physicians to screen, monitor, and prescribe nutrition safely. If we slow down, replace electrolytes, provide thiamine, and advance nutrition thoughtfully, we can really prevent most complications. And finally, remember that prevention doesn't stop at discharge. Patients need clear follow-up, access to nutrition expertise, and protection from the gaps in insurance coverage that so often happens that puts those patients back into the hospital. So if there's one takeaway from today, it's that refeeding syndrome is preventable, but only if we look for it, plan for it, and act. So next slide. Thank you so much. Next, Dr. Syed will monitor a panel discussion.
Thank you, Amanda. I'm Kanza Syed. I'm one of the staff physicians here. My areas of expertise are clinical nutrition and medical pancreatology. So now we will be taking questions from our audience so that our faculty can respond to them, maybe have a very brief discussion. We did have one question during the talk, and we perhaps would like a little clarification, but I can read it out for all of us. And the question was, from Bikram Paul, in the mucosal injury, I will suggest to add chemotherapy, especially oral chemo. Any suggestion for management?
I think I requested a clarification of the question. I'm not sure if it was intended towards like something like chemotherapy-related mucosal injury or checkpoint inhibitor colitis or enteritis. So it just requires a little bit of clarification. But, you know, just basically we end up doing symptomatic management, and sometimes the therapy ends up being altered due to GI side effects. That's a close conversation with the oncologist.
Great point. We do not currently have additional questions, so if you have any pearls on this topic or adjacent topics, it would be a good time to share. And if no one else has questions in the next minute or so, we will begin to progress toward the case presentations. And I think monitoring the chat, since I don't see any, I think it's time to do so. So we will now get started with Dr. Socio's case presentation.
Thank you so much, Dr. Syed, for the introduction. I'm one of the nutrition fellows, and I will be presenting 2 cases today. Next slide, please. Our first case today illustrates refeeding syndrome. I present to you a 73-year-old female with an extensive past abdominal surgical history, who eventually ended up having a extensive small bowel resection that was complicated by short bowel syndrome since September of 2022. In September, she was admitted for AKI secondary to dehydration and severe malnutrition. And of note, she was admitted to an outside hospital before she came to us for a catheter-associated bloodstream infection, which was addressed by removing her Hickman catheter and by undergoing a treatment with cefalozolin. Next slide. The patient's anatomy illustrates that she only had about 195 centimeters left of small bowel, which is just short of the 200 cutoff to qualify for short bowel. And this is very important because this is the indication for her PN use at home. We can see that she was using PN at home since February of 2025, and it was unfortunately discontinued in August of 2025 because during the hospitalization for catheter-associated blood infection, she did not want to proceed with central line placement again, so her TPN was put on hold. And when we saw her in consult, at that point, she had been off TPN for about 16 days. Next. In terms of her weight loss, as we can see over the period of a month, she lost about 5.3% of her weight, and her intake was well below 75% of her estimated energy needs for the past 14 days. And on physical exam, she exhibited moderate muscle loss as well as mild fat loss. Next. In terms of malnutrition diagnosis, based on her weight loss and her moderate muscle loss, she qualified for severe malnutrition in the setting of acute injury or illness. Next slide. I know Amanda Bodie already spoke about refeeding syndrome, but I will just refresh our mind for a second. We have to be careful about electrolyte imbalances when we start feeding patients, whether we do so PO, enterally, or with parenteral nutrition. And the electrolytes that we have to pay special attention to are phosphorus, potassium, magnesium, and sometimes glucose can also become elevated. Next slide. For her patient specifically, these were her labs prior to peripheral parenteral nutrition initiation. And as we can see, our patient's potassium, magnesium, and phosphorus were actually well replenished, with the phosphorus being on the higher end. Next slide. For that specific reason, when we started peripheral parenteral nutrition, we started, of course, with a very conservative amount of dextrose and calories, but didn't necessarily proceed to replete magnesium, phosphorus, and potassium because those were actually in a good range to begin with. Next slide. On the day after initiation of PPN, we can see that she started exhibiting evidence of refeeding syndrome by potassium and phosphorus, which were 3.6 and 3.5 respectively. Next slide. Based on the electrolytes, the regimens that we saw, we addressed the potassium and phosphorus and started to also increase the dextrose conservatively. And we did so with baby steps in a stepwise fashion. Next slide. The next morning, we obtained more labs, and as we can see, refeeding syndrome was still present, but to a much lesser degree. In fact, phosphorus was the only electrolyte that was abnormal. Next slide. So we further made a modification of our electrolytes by adding more phosphorus to optimize our patient. Next slide. And then the following day, we were actually able to obtain central access, which for us also means that we can be a little bit more liberal in terms of osmolarity. Next slide. And then our final PN modifications, and I just want to remind ourselves that at this stage, we are administering central parenteral nutrition. And as we can see, because of the osmolarity liberalization, we were able to also go up on the amino acids as well as introduce some of the fats to make our final PN bag. Next slide.
And now we'll pause very briefly to answer a question that I see Dr. Paskey is already attending to in the chat. It's actually from Amanda's presentation about the recommended calories per kilogram and whether that's based on current weight, IBW, or ABW.
That's a great question, and we don't really know the answer to that. If you look at the Aspen Consensus Guidelines, it really doesn't answer that question, but what I would do in practice is really use their dosing weight, a dry weight, a current weight, or you can also use like an adjusted body weight. If they are obese, you could use a BMI weight of 25, 24. That kind of area. But I think the main thing is to use at least a third or less of the calories that you would start at, and then gradually increase over several days from there.
Thank you for your response, Amanda. So I think since there are no more questions and we are on a bit of a brisk timeline, we will move on to Dr. Zemanik's presentation.
Good evening, everyone. So I'll be presenting a case on TPN optimization in setting of severe malnutrition. Next slide. Next, please. Some no disclosures to report. Next. So our 4 objectives today are to assess the importance of screening for malnutrition, review nutrition management, and discuss the role of TPN in surgical optimization for patients, and then discuss medical and surgical management in the setting of necrotic small bowel. Next slide, please. So this is a 33-year-old gentleman, came in from out of state. He has a history of necrotic bowel. He was referred to the small bowel for small bowel transplantation. On presentation, he weighed 109 pounds with a BMI of 13.3, and he had previously been on TPN. This patient was recently diagnosed with UC in the prior 6 months. He was trialed on budesonide, mesalamine, and Remicade. He has a history of smoking and alcohol use. Next slide, please. So prior to coming to Cleveland Clinic, he had a total abdominal colectomy and ileostomy. He had complications of small bowel bleeding and necrosis. He underwent resection and coil embolizations. His anatomy included G-tube, D-tube, and a J-tube. Next slide, please. So on admission, he had ileoscopy. It showed ileostomy was pale, mildly stenotic, and he had pseudomembranes protruding. We have 2 of the images that were captured on ileoscopy resembling the pseudomembranes and the denuded mucosa. Next slide, please. So our initial nutritional plan was he had high output ostomy, so we restricted his fluids, restarted his TPN for short bowel syndrome. On nutritional assessment, he was found to have severe malnutrition. We started him at 50 kilocalories per kilogram for weight gain. Next slide, please. As well, we started him with multivitamins, trace elements. He was on a PPI for acid reduction, and we continued lab monitoring for the TPN that we routinely check daily and weekly, and we check some vitamins and trace elements. Next slide, please. So of note, he had a low vitamin A, C, D, E, as well as low carnitine, selenium, copper, and zinc. Of note, the CRP was mildly elevated. However, this has been chronic. Sometimes when CRP is elevated, it's difficult to assess lab work, but his vitamin C was super low, which was of note. Next slide, please. So from a nutritional supplementation standpoint, we started him on multivitamin trace elements. As we were limited by the amount of vitamins we could give him through the TPN, we started him on a nightly banana bag as well for additional vitamin support. He was on levocarnitine, selenium. We initially started him on vitamin D 50,000 3 times weekly. However, due to his levels, we had to increase that to daily. We were able to give him vitamin A and E through liquid formations, and he received daily albumin per the surgical team as his albumin levels remained low with the high output ostomy. Next slide, please. So related to the low vitamin C, we initially started him with daily IV daily vitamin C for 7 days. As you can see, he responded pretty well initially. So then we went to weekly checking the labs with infusions, and he had dropped a little bit. So then we had to increase his vitamin C to twice weekly. Next slide, please. With regard to his weight, coming in with such a low BMI and weight, we had to increase his calorie needs throughout the several weeks of admission. So he went up from 50 to 60, 65, and then was as high as 80 kilocalories per kilogram. Next slide, please. From a surgical perspective, the goal weight would be to get him to 140 pounds through improving his nutritional status for him to be a candidate for small bowel transplant. And so one of the challenges we experienced was getting a dry weight or a standing weight on the patient, as he was mostly bedbound. And during the first several weeks, even with increasing calorie needs, he had limited improvement in his weight. Next slide, please. So during his hospital stay, he did have GI bleeds that did require transfusion, resuscitation. He was started on a short course of IV octreotide that was then stopped. As well, he had ulcers that were non-healing on his feet, and he required amputation from that standpoint, which also challenged or made it more difficult to get standing weights on this patient. Next slide. We were ultimately able to get him up to 127 pounds, so closer to that goal of 140 pounds. Some of the strategies that we implemented were going up on the calorie needs with the TPN, with the GI bleeding and the joint pain that the patient was experiencing with the low vitamin C. We tried to supplement that. Initially, he wasn't able to tolerate PO, so we had looked into exploring a vitamin D cream with endocrinology. As well, we discussed the possibility of testosterone implementation to help with muscle mass gain. However, the risk benefits were decided that that would not be a good strategy in the inpatient setting, but could be considered outpatient. And something of note, indirect calorimetry would be a great study to try to give us a better guideline of what his true caloric needs were. We weren't able to get that inpatient, but that would be something we would also look into. Next slide, please. One of the main points I want to kind of discuss with this presentation was his low vitamin C levels. And so talking about some of the findings that we've seen patients with scurvy. So they're generally tired, have low blood counts, joint pains, bleeding, some bleeding in their gums is a common symptom. So our patient did present with many of these, and we found that with the supplementation of improving his vitamin C levels, the bleeding has improved, and he's had improvement in his joint pain as well. I'm happy to take any questions as well. I know we're coming to the end of time.
If there are any questions, we welcome them in the chat.
I actually have a couple comments from the panel point of view. For Jessica, for your case, I noticed that, with some signs of refeeding syndrome, maybe Amanda can comment on this, you adjusted the electrolytes, but you also increased the DEX. I wonder if you could comment, the rationale from that. And then, when you see that increase of DEX led to persistent refeeding syndrome, do you ever dial back on the dextrose? I would love to hear Amanda's thought on that case as well.
I'll let Jessica speak first.
Yes, I think it's very reasonable if there is a high degree of refeeding syndrome based on the electrolytes. So for example, if all of them, magnesium, phosphorus, and potassium are all low and well below what we would expect, to perhaps hold on going up on the dextrose for at least one day. I'm not sure of any specific guidelines out there. I'm not sure if Amanda has any pro tips on this, but I think it is reasonable, perhaps if there is a severe imbalance, to hold for one day, be conservative, and go up the next day on the dextrose.
Yeah, I can speak to the Aspen consensus recommendations for this. The guidelines are really, if the electrolytes are out of balance, to cut the nutrition back in really most ways. My perspective is really that's very important for parenteral nutrition, because you don't have the need for absorption. However, in enteral nutrition, I think that we don't maybe need to be quite as aggressive in cutting back if we are able to treat it. Another factor is really how frequently are you going to be able to be monitoring these labs? So if you're monitoring closely and you're monitoring signs and symptoms clinically and also getting labs pretty closely, I think that you could be a little less conservative and cutting way back on the nutrition. But it is important to reduce the glucose load when you are having refeeding syndrome, and to then kind of reassess after you get that next set of labs what you want to do for continuing forward. Dr. Paskey has a note in that says her personal practice is to provide 1.5 grams per kilogram per day of dextrose and TPN at risk for refeeding syndrome as a start. So it's really that insulin and that glucose load that's really driving the refeeding syndrome.
Yes, and Dr. Paskey's comment is in response to Julia Warren's question that for those that have a known refeeding risk, do we ever prophylactically give magnesium, phosphorus repletion, similar to some protocols used for patients with anorexia going through structured diet plans? Personally, if I notice that the magnesium and phosphorus levels are low before starting parenteral nutrition support, it is ideal to optimize those values before starting, but only if we're able to get repeat labs to assess the new requirements of the patient. But that is speaking anecdotally from what I tend to do. And if others would like to add their 2 cents, please feel free.
I will say that I know in Europe some clinical situations they are doing a phosphorus repletion in advance, but you have to be really aware of the renal condition of that patient and how they might react based off of their underlying conditions, and also have that opportunity to monitor them closely. You don't just give it to them and send them home.
Yeah, I think there's a lot of debate about this. You know, in some guidelines, they recommend checking the electrolytes twice a day and repleting, but you actually end up in this sort of position where, you know, by the time the labs result, and you have to remember those phosphorus infusions take like 3 or 6 hours if you're going to be giving 30 millimoles. And then, you've already got another lab coming back and you haven't even finished your infusions yet. I think that, you know, the biggest key for refeeding syndrome is that you want to prevent it. So you've got the extra thiamine, you're being conservative on the dextrose, you're checking your labs on a regular basis and just gradually getting up to your target calories. People don't get severely malnourished to get high risk for refeeding syndrome overnight. This is a process that happens over a long period of time to reduce all of those stores. So you don't have to get up to goal in 2-3 days. You have time. And to sort of be with the patient, if you're doing a really good job, no one even knows refeeding exists because they don't see it.
Thank you, Dr. Paskey. So we have just about 2 minutes left. So we, again, welcome more questions that the audience might have. I see Dr. Russell has written a comment about what she does, and she limits the total grams of dextrose to start at 100 grams in higher weight patients for PN start in refeeding syndrome. So I also do that. The magic number for me was 100 or 150 grams of dextrose.
You just have to remember to have enough dextrose to prevent ketosis. So that's why you still need to provide like a minimum amount, and it'll be a little bit different for everyone.
Great. And we have another comment.
No, go ahead.
Sorry. Vitamin C supplementation is really a key micronutrient to consider. And we got thanked for our presentation.
Yes, and I think on that note, I have a question for Mark. You know, that was such a complex patient, and I think highlighting in the chat, you know, with Dr. Paskey as well, like this patient, we were really pushing the calories and monitoring very closely, and this would be the ideal patient to do indirect calorimetry and looking at highlighting that if you just go by predictive equations, you're significantly underfeeding these patients. So very high metabolic drive, you lose a lot of protein with GI bleeds. So any comments on that, Mark, of kind of maybe the nervousness of pushing the calories in someone like this?
So I think the important thing is to kind of go slow and to kind of monitor the weight as well as you can. We did have to rely on some bed weights, but we were able to calibrate the bed to check that it was a reliable weight. As we continued the TPN and we went up on the dosage, the patient did eventually start to gain weight, which was a positive. And we've actually been able to back down on the kilocalories now. So it's continued to reassess the patients while they're in the hospital, continue the physical exams every couple weeks, and monitoring for making changes if we need to go up or down on calories.
I think that's great. And it highlights, there's a little bit of, metabolic changes and how are they utilizing those substrates. And, there's a big need in nutritional research to look at that. So maybe next year we'll have more data to discuss. So thank you so much. I'll be closing out this session. Thank you, Dr. Syed, for moderating and for the case presentations. And then also, I hope you enjoyed tonight's presentation. We have another Digestive Diseases Live from Cleveland Clinic coming up, entitled Advances in Intestinal and Anastomoses, with our colleagues, Dr. Gorgon and Dr. Liska. So please join us on October 22nd, 2025 at the same time. And there's a QR code to register. And thank you so much for attending today. The registration is also in the chat as well. And I hope everyone has a great evening or great day, depending on where you are in the world.